interesting topic, and also there is some controversy regarding the use of fluorides currently in dentistry. So I thought this would be a good opportunity to exchange the current evidence so that we can get back to our practices and inform our patients who are in doubt and emphasize the importance of fluoride in especially practicing minimal intervention dentistry. Again, that's one more thing that I felt. We all learned fluoride as a preventive protocol plan, but fluoride is omnipresent. It is there throughout. So let us quickly see how this is going to benefit us. But before that, I will fail in my duty if I don't thank the IDA Tiruvallur branch. As everybody knows, Rajshekhar has been really the backbone and driving force of this branch. The amount of dedication, method, it's all very organized, and I'm also glad that it's not too big a branch that things get diluted or there's too much of power politics and all that. Administration is different, but they always encourage science and dissemination of knowledge. That's again one more thing that I found very exclusive to your branch, and congratulations to you on that. இல்லைன்னா என்ன ஸ்பீக்கராக கூப்பிட மாட்டாங்க because in 2013 I was called by IDA Kanchipuram branch, heavily funded by Dentsply, to speak on rotary endodontics. I think that's when everybody was into rotary doing course and all that. So I went there. So one problem with me is எனக்கு வாயில சனி. Now whatever is there, I just state it the way it is. Okay, so I might be liked for it, but a lot of people hate me also for it, but I am not able to control that. So in that lecture, I told everything about torque, this, that. No, I gave them the science, how to choose a file based on this, based on that. In the end, I concluded saying files are rubbish. They only give you a circular canal. Actual success is with the irrigation protocol. So don't waste too much time on files. So I think the manufacturers were like extremely disappointed, like what rubbish she's talking. We have come here to sell files, and she's talking that it just gives you round canal, doesn't do anything much. So I state the facts the way they are. If people like it, want to change with it, it's good for them. If they don't like it, it's still good for them, because one person's opinion doesn't matter, but I feel that I should be honest in whatever I say and do. And probably that's what has brought me to this extent in my life, so I wouldn't want to change that. But kudos to Rajshekhar, I'm very scared of him. One person I'm little jittery about is him. He's like, correcta vandrunga, inge vandu tiffin saapidunga, இல்லைன்னா சாப்பிட்லனாலும் பரவாயில்ல, நீங்கள் வந்து கரெக்டாக டைமுக்கு ஆரம்பிச்சிருங்க அப்படிங்கிற மாதிரி சொல்லாமல் சொல்வார். இட்ஸ் வெரி நைஸ். நோ, இட்ஸ் தட் கைண்ட் ஆஃப் லீடர்ஷிப் குவாலிட்டி வில். ஸோ தட் photo also, I mean the logo also, this is our branch logo, requesting you to please use. So when you ask like that, you can't then not use it. So then we actually, when you go and speak in international forums, they give you a template and ask you to speak according, put everything in that template. So I think that kind of ownership and that kind of belonging to the branch, no matter how big or small, it is respected, and I wanted to respect, so I have all that in my slides, and that pushed me to put my logo on this side, like அவங்க மட்டும் அவங்க லோகோவை ப்ரொமோட் பண்ணுறாங்க. ஸோ லெட் மீ ஆல்சோ ஸ்டார்ட் taking responsibility for what I stand for. So this is what, it's a trademark name, the Minimalist Dentist. I'm planning to do a lot with this, under this banner in the future. So not in the form of lectures or workshops. I think that's a very boring format according to me. Okay, I think we should have more like clubs and discussions where it happens across the table. So you will have to watch out for that. Okay, two things before we get into the topic. I always have this in all my presentations. It's a statement by G.V. Black. I just want you to read it once. It's told more than a century before. Unfortunately, in current day also, we are functioning only as mechanics, in my honest opinion, because we don't spend time to understand what is causing the problem. The problem is also intrinsic because the Dental Council has not revised the syllabus to teach us what is causing the problem. So when I moved to Savita and they wanted to start a separate department of cardiology, I was very happy because they wanted to bring together 4 departments, get their thought processes right, so that the concept is delivered correctly. So we have my department, pediatric dentistry, oral pathology and community dentistry together and function together when we are administering cardiology as a subject to third year BDS students. It's a university exam subject. We have theory, practicals and all that. They have to clear that in order to go to final year. So it's that serious and I'm very thankful to the management and Dr. Deepak for having envisioned something like that. Okay? So this has to change. For this to change, we need to spend some time reading the literature which has not been accessed to us. I've shared a lot of literature with Dr. Raghu and Dr. Rajshekhar. So I'm sure they will share it. Please go through that because what is practiced and taught abroad is completely different from what we are learning. I am trying hard to change things. This current edition Schaefer's chapter on dental caries, I was fortunate to contribute to that chapter. I told SPS sir, whatever is written in oral pathology, dental caries is wrong. We cannot teach this to students. So then he invited me to author that, co-author that chapter. So slowly we will try to effect change. So this is the current definition for dental caries. Even if you remove one aspect of this, you will not develop cavities. It is that simple. It's a biofilm mediated, diet modulated, multifactorial, non-communicable dynamic disease resulting in net mineral loss. Only if the mineral is lost, you can call it as dental caries. Okay? Otherwise, it's not dental caries. You cannot have just one entity. Everybody says antibacterial agents or killing streptococcus mutants. The science has moved away from streptococcus mutants. Streptococcus mutants is no longer the villain in dental caries. It's a group of acid producing bacteria that is implicated in causing dental caries. So let's forget using antimicrobials to combat caries and try to see how we can handle this biofilm, because the biofilm is what is responsible for the entire problem and not the bacteria. They are all commensals, they are all just existing in our mouths. They have a party when we go berserk. Okay? So if you take even one word out of this, you can prevent caries. So who is the youngest in this lot? Who finished BDS or MDS most recent? Not by heart. I said by experience. When did you finish? Your third year master's program. Oh. என்ன மாதிரியே ஒரு OE கேண்டிடேட்லாம் இருக்கிறத பார்த்தா சந்தோஷமா இருக்கு. Okay, who is the next youngest? So all of us have graduated from BDS maybe 3-4 years at least minimum. I'm 18 years old, no, from my masters. How many of you have developed fresh cavities after you finished your BDS or masters? Fresh primary caries. I'm not talking about cavities that were restored, which filling failed, you developed recurrent caries. I'm not talking about that. After you finished your program, how many of you have got fresh primary caries as dentists? அப்படியா சார்? புதுசா cavity. Upper 8 la கணக்கே கிடையாது சார். Upper 8 is you have developed buccal caries. See, 8s are a very tricky thing. It's purely because of the position in the mouth. So even if you see during recording DMF and all that, they don't take 8 into account because 8 and orthodontic treatment is like always high risk. Leaving that, if you notice for yourself, none of us actually develop cavities after our graduation. You have developed. Huh? Yeah, so you will have something which is off, but in a normal situation, so if you see, take in a room of so many, it's just less than 1%. Why are we not developing cavities? Are we all brushing twice daily, honestly? No, even I don't brush twice daily. Okay, I told you, no, I'm very honest like that. Do we all floss? None of us floss. Do we not eat junk food? We all the time eat junk food. Do we avoid Coke, Pepsi? No. Diet Coke இது அது சொல்லிட்டு something will have. So we don't do anything that is different from the general population, but we don't develop cavities. This is something very, very important for all of you all to take note of, because what you are doing for yourself is what exactly you need to help the patient do. That's it. This is not rocket science. So today in my lecture, I am not going to teach you science. Fluoride is something that you all learnt. Yeah? Today's lecture is only to help you think differently. And so to think differently, let's look at this slide. In this, which one in your private practice you think can, இது work ஆகலையா? நான் பேசுறது கேட்கதானே கேட்குது. I think they can listen.
Okay, if it is okay for you.
Yeah. ரொம்ப கத்தி பேசுற மாதிரி இருக்கும். Yeah, in this, if you have to leave behind a specialty or a treatment, இது எடுத்துருங்க. அப்படி கேட்குமா?
அப்படியே இங்கே வச்சுக்கோங்க, no problem.
Which one can you leave or you don't do that much? We are all having general dental practice, no? Nobody is a specialty practice. இதில் எது விட்டுடலாம்? லைக் இது இல்லைனாலும் பரவாயில்ல, என் ப்ராக்டிஸ் ஓடும். டிஎம்ஜே இஷ்யூ அதெல்லாம் நாங்கள் இது சாஃப்ட் ஸ்ப்ரிண்ட் போட்டுக்கோங்க, எதுனாலும் சாஃப்ட் ஸ்ப்ரிண்ட். எப்படி ஆல் ஸ்கின் டிசீசஸ் வி கிவ் கார்டிகோஸ்டீராய்ட்ஸ் அது மாதிரி. ஓகே, டிஎம்ஜே இஸ் அவுட். தென் do you all focus so much on pediatric practice இல்லை வந்தபோது அப்பப்போ ட்ரீட் பண்ணுறதா? Hey, you need to interact, man. This is a very simple question. Which one you think that if you leave behind, nothing is lost, you don't lose much, or you don't know how to do, like FMR la eppadi plan pannum theriyadu, but FMR therilanalum I will still be able to manage practice. Cavity prevention nobody practices, let's be honest. அது இல்லைனாலும் பண்ணாலும் பண்ணலனாலும் ஓகே. So the entire purpose of this slide is to come to that, which I will tell in the end. What else can you leave behind? Periodontal therapy, do we take it seriously? Scaling, அதுக்கப்புறம் we don't use that probe and all, எங்கே pocket, we leave that behind. Main, what is our breadwinner? Orthodontics, exo impactions, RCT and crown, implantology, smile descending also we don't pay that much attention. எனக்கு ஆன ஒரு பேஷண்ட் வருவான், வந்தானா பார்த்துக்கலாம். Yeah, we'll call some consultant at that time. So which of these you do by yourself? You're confident to do by yourself without a consultant? Scaling, fillings. I'm sure exo and impactions also, right? ஒரு அளவுக்கு. RCTs? Yeah? So when I put all these things here, and you also would have noticed that a lot of programs that happen around you at state level IDAs or even our national level conferences, if you see hands on, even today, it is to teach you how to do a particular clinical skill, right? Why? Because we think if we learn that skill, if that set of patients come to our clinic, we will be able to handle it ourselves. Yeah? Most of us, because implantology is not a separate specialization, implantology is a huge money maker, so we invest time doing fellowships and going for courses and learning. At least few of us do. So, and also all the programs are targeted like that. If you see, it's all teaching us how to do well clinically so that we make money, right? We don't sit and discuss concepts. அன்னைக்கு அப்படி பண்ணோம், இன்னைக்கு இப்படி மாறிடுச்சா, என்ன மாறிடுச்சு, இனிலேருந்து 5 வருஷம் எப்படி மாற போகிறது. Nobody talks to you about that. So have you wondered why this way of what drives dentistry is the question that comes next. If we are focusing on Invisalign over fixed braces, if we are choosing how to do implants, how to place implants, if we are choosing conscious sedation and not trying to do cases and pediatric cases under GA, all of this, who is making us or pushing us into these things? What drives today's dental practices?
The product and the company.
Perfect. It is always the industry that is driving us to acquire knowledge, giving us or selling us the hope that we will make more money if we embark on that route. It's not our patients. Patients don't come to us saying that I want only implants or I want only that. They come to us with a problem. I don't have teeth, not able to chew, or most common problem they come to, they don't come to us otherwise. Only if they have pain, they'll come to us. Yeah? Because that part, I'm very sorry to say, nobody has tried to educate them upon. Neither IDA, nor DCI, nor state health government, nor central health government has actually spent the effort in order to educate our patients to have better oral health. Yeah? So because that system has failed, there's a huge lack in to make money for us. We don't know how else to make money. If patients are not aware and nobody is there to educate patients to come to us on a routine basis, then how are we to survive as professionals, right? There is when our vulnerability is capitalized by industrialists who push products to us. I've seen like so many people post on Instagram, that Instagram is another full hyper area for me. This product is better over that product. Like how many products do you need? You don't need too many products to run your practice. You need optimum setup. You don't need everything, right? So instead of optimizing the dental practice, our tendency to always look up which is latest in the market. I know this dental expo is such a huge craze. Yeah, everybody goes there. I do not know why. I have not attended a single expo in my life. I run a high-end practice in Alvarpet. We place all our orders on Dent Cart or whatever because it comes with the same concession. We have never, both my husband and myself, we have never felt the need or urge to go to a dental expo and explore products. Going to a dental expo, in my opinion, again, everything is only my opinion, you're all entitled to do whatever you feel right, is like going to lifestyle on a sale, RD sale. You will be forced to buy a lot of things because it is very enticing. We do make a list, but we don't stop with that list. Yeah? And that list doesn't have anything about cavity prevention or preventive dentistry at all because you don't have products that promote preventive dentistry. Prevention is a way of life. It is not product oriented. You prevented cavities in your mouth only by changing your lifestyle or brushing habits. You have not used anything in particular. Neither are you undergoing fluoride varnish biannually. You are also using the same Colgate Total toothpaste. Yeah? It is only a lifestyle change and a mindset change which we have imbibed subconsciously, which we are not selling to our patients. But this is something which is easily sellable to our patients. And selling this concept and making money out of that is actually double-edged. You will make money also, you will have a very ethical practice also. So let's see how to go about this. So when we say invasive therapy, when you take a burr and cut a cavity, it's invasive. Okay? So we've all learned something called as preventive resin restoration. Yeah? Or G.V. Black's concept of extension for prevention became preventive resin restoration with the advent of adhesive technology, wherein you enlarge the groove with a Fisher-Roteby burr and use flowable composite. That also is considered as invasive. Currently what they say, if you have cavities even on the fissures and grooves, you don't cut it. You just acid etch and use pit and fissure and seal it, even if you have cavity. See, the current way the world is working is non-restorative management of cavitated lesions. So they don't want to do fillings at all. The reason for that is again out of studies. So this is the failure rate percentage. So if you see, cervical abrasions fail a lot when restored with composite. That's because of the bending forces. There's compression and tensile forces happening constantly. That is in permanently. The next failed cases are with your class 1 cavities. And then you have very high failing rates with primary cavities restored with composite. Now we are in a crux situation where we will no longer have access to amalgam fillings. Amalgam fillings in permanent teeth have known to have an exemplary track record. If given a chance, I will have only amalgam fillings in my mouth if I ever develop cavities. But unfortunately from 2032 onwards, you will not get amalgam. So you are left only to deal with composite resins or alternatives. There are much Cention and all that is coming up. But when you cut and place a filling in a patient's mouth, the clock starts ticking then. So this is very clearly explained by what is called as the death spiral, which is again the concept in which all the insurance companies work abroad. So they have understood that if you make a cavity in a patient's mouth when he's 20 years of age, even if it is the smallest round burr or your PRR filling that you do, you cut a cavity and restore it with flowable composite. It goes through a cycle of restoration and re-restoration. So it can fracture or caries adjacent to one chipped margin, the marginal leakage can undergo cavity. That will again require a refilling. Then second refilling, or probably you use a crown, then it goes deeper. By the age of 40, the tooth goes into root canal treatment. Again, all root canal treatments are bound to fail. Don't sell or have the illusion that once you've done root canal treatment, it is for life. An average lifespan of a root canal treated tooth is 6 to 7 years with a 92% success rate. So if you are establishing a practice and it is about 10 years old, you will see your patients coming back with infection. Whether they develop pain or not is a secondary issue. But you would have seen that the root canals that you did 10 years back all have a small lesion. It is normal because that's the lifespan of any root canal treated tooth. So that goes into retreatment and then finally extraction. Yeah. Now in this window between root canal and treatment and re-root canal treatment, again industry is trying to push very hard to promote implants because they say that root canal cannot be 100% cleared. There is always some residual bacteria remaining in some nook and corner of the root canal which causes breast cancer. All that is being promoted and all that is being directly targeted to the general population. It's all over social media, it's there on YouTube. There are Netflix documentaries on this, okay. So you don't over or underestimate the power of the industry. They can go to all length and breadth to sell their product. So if you do a filling, an MID filling at the age of 20, that tooth is bound to be extracted at the age of 60. And we are doing this repeatedly in our patient's mouth. So as cariologists worldwide, we say that don't even fill cavities if it were in enamel. Just acid etch and use spit and fissure and seal them. If there are cavities on the smooth surface, don't do veneers or do marginal roughening and then do flowable composite because all those are bound to fail. An average composite filling will last you for maybe 5 years. A class 2 composite even lesser, 2-3 years max, even if I do it, okay. We all are enamored by those international speakers who come and show us 5 years, 10 years. அதெல்லாம் வந்து எப்படி வந்து ஐஸ்வர்யா ராய் இருக்காங்களோ 1 in a million will be like that. So it is entirely got to do with clinical skills. They charge so much to do a composite filling that they will do it only under rubber dam isolation. They will use the best of contact matrices. We also want to do like that, and I know a lot of young dentists invest a lot into infrastructure. They buy Palodent system, they do this, they do that. But a patient will not pay like 10,000 rupees for a class 2 composite filling. Let's get practical here, okay. We need to design our practices according to the challenges and demographics of our country, of our city, of our town. So, but prevention is the same. When you practice prevention, the methods and materials are the same and they are very, very simple. So when you restore a teeth only for these 3 cases. When the patient cannot maintain plaque control, To protect the pulp dentin complex, if the cavity has gone too deep and you want to protect the remaining pulp, then you place a filling. You restore form, function and aesthetics. If the tooth in front is not looking good because of cavity and the patient is wanting, then you fill it. So what cavities you don't fill? Say for example, there's a class 5 cavity on the canine, upper canine. Patient is able to brush, it is arrested, you don't fill it. If there's a buccal caries and the buccal caries has opened up and the patient is able to brush and floss, it's not functionally limiting, he's able to chew. You see dark black caries, don't fill it. That's the concept now. Because when we are trying to remove this arrested caries and do a very nice filling, the challenges of biomechanics acting on that filling is much, much greater than if it was left alone. Okay? So apart from these 3 scenarios, we don't do filling at all. And it is just to see how we can reverse the active state of dental caries into an inactive form without doing much of a treatment. So the current definitions for everything is given in this thing, in this paper. I've shared that with Dr. Raghu. He will be sharing it for you. So main concepts are inactivation and control of the disease process even if the tooth is cavitated. So why I am writing this here is, in everything you have fluoride coming in place in some form or the other. That's what we will be quickly seeing. So you will be using fluoride as a continuum and not just to prevent cavities. It is not restricted to your pediatric practice. When you say fluoride varnish or fluoride, don't restrict your mindset to just your pediatric practice. A huge group of adult population also need fluoride varnishes, because if you are doing an active periodontal therapy and you are seeing gingival recession, interdental what to say, gaps, you all prescribe immediately water floss, right? Why? Because that industry promoted water floss for interdental brushing. But nobody said that interdental areas are vulnerable for food retention, biofilm formation, inaccessible for brushing. Water floss will only remove the junk of the material. Biofilm will not be removed unless they take a bristle brush and brush it, which நாம்பளே floss பண்ணுறது கிடையாது. பேஷண்ட் வந்து bristle brush எல்லாம் எடுத்து ஒரு பல்லுக்கிட்ட பண்ணுவாங்கன்னு எதிர்பார்க்கவே முடியாது. So when you have a patient with gingival recession, undergone periodontal therapy, you have to treat that patient as high risk for dental caries, period. 3 months once you have to apply fluoride varnish, period. And it also gives you scope to make money once in 3 months from that mouth. It's that nobody has told us. Yeah? So to preserve the dental hard tissues, avoiding this restoration, re-restoration cycle. So if you have a tooth restoration interface, it breaks down because of 2 reasons. One is plaque buildup or biofilm buildup along the cavous surface margin, or the occlusal forces. So if you have adjusted the occlusal forces well, you just protect the existing cavities with fluoride varnish once in 6 months. It is going to increase the lifespan of your restoration. Okay? And then finally, to preserve the tooth as long as possible in its original form without too much of filling and doing a lot of things. So when you come to non-restorative strategies, the first one is beyond our thing. It's just like individually you can just educate the patient. I think patients are more aware now these days, at least from the area where I practice. They don't give sweets to kids and all that. They brush twice daily in their children's mouth and in their mouth. But that's something that we can encourage. Biofilm control is very, very important. You have to teach how do you all teach how to brush? Very simple but an interesting question. I want honest answers. Yes. எப்படி சொல்லுவீங்க நீங்க? You can teach. We'll all learn.
And grinders on the occlusal platform, circulatory motion, same way upside and buccal side. And do not, I insist what not to do.
Sure.
Like,
do not do that. No, horizontal zigzag motion, because it.
And take a pea size of brushing, watching this morning. Mostly I just say what not to do.
Most of us are also saying the same thing, right? Where patient கேக்குறாங்களோ இல்லையோ, like mostly this advice comes when we are doing cervical fillings. Yeah, திடீர்னு அப்போ தான் நம்ம வந்து we want to change their brushing habits. இப்படி தேய்க்காதீங்க சார் அப்படின்னு. Yeah, but we don't do it in routine dental practice unless the patient asks. How many of you voluntarily tell all this to patients? ரகு கணேஷ் வேற பிறவி. ரகு கணேஷ் எங்கேயோ இருக்க வேண்டியவர். You also tell as a routine, yeah? So that has to be routine, but you know what I do when I feel that the patient's oral hygiene levels are not good, especially in kids? The first visit when they come, I don't do any treatment. Even if they come with a chief complaint of pain, then you just manage pain by, you know, analgesics, if it is a swelling, going to pulpectomy and all that. But first visit I don't treat at all, because when they come with pain and we inflict more pain, that's when dental anxiety sets in. And that's the day they start hating us and continue to hate us for the rest of both lives. So I don't want people to look at dentists and dental clinics as a place where they go to relieve pain. Dental clinics have to be a place of an oral health wellness center. It should be like how ladies go to get their pedicure, manicure done. They should look forward to coming there. Yeah? So that's actually the reason why we all have dental practices. And how I make people learn biofilm control is to apply the tri-plaque disclosing gel, show the kids where it is. I do that for my son also, because he is not immune to, you know, brushing well. So when they see in their mouth where plaque gets accumulate, have you all tried disclosing agent in your mouth? Yeah? It's very difficult to get rid of that unless you use the right strokes. So I am also a part of the Tamil Nadu state government oral health policy drafting committee. I made it compulsory to include 1 day tooth brushing in school children in the class of 7th standard on Mondays, or any 1 day, as mandatory after lunch, using disclosing agent, because that's the only way they will learn how to brush well in their mouth. நாம் வந்து மாடிஃபைடு பாஸ் டெக்னிக் இதெல்லாம் சொல்கிறோம், அதெல்லாம் வந்து நம்ம எப்படி பெரிய படித்தோன்ட்டு. How we were taught tooth brushing. It's not about how the patient will be able to relate. We tell keep it at 45-degree angle between the gum and the tooth margin and brush. We learned tooth anatomy and dental anatomy. They have not learnt. It will just go past their head. But if you stay in their teeth and tell them that these are the pink areas or the blue areas you need to focus on, they'll go home, stand in front of the mirror and try to get rid of that. Okay? So that is something that is as simple. And of course, control of mineralization, you have fluorides and non-fluoride methods. So if you just learnt about fluorides today and didn't focus on the other things, again nothing is going to work. So I didn't make my presentation to teach you about fluorides. We all know about fluorides already. So fluoride comes under that segment. Okay, usually traditionally it comes between that remin demin part, but also now after restoration, to control the restoration or caries activity around restoration, fluorides in the form of toothpaste and varnishes have been implicated. So these are the various fluoride types that can be applied. Okay, you can use this slide for reference. One thing that I want to highlight here is to treat cavitated lesions without restoration also they use fluoride in the form of SDF. So SDF is silver diamine fluoride, which has been introduced in market about a decade before, and it has been revolutionary. If patient doesn't want treatment or cannot afford multiple cavity fillings, you can just apply silver diamine fluoride for the time being and control the cavity. No, you can instantly convert the active caries lesion into an inactive one until you can call them back and restore in future. So that's the recommendation of where you will use what kind of fluoride and what are the surfaces, both for control and prevention. Now fluoride toothpaste is something that is highly underrated. I have seen a lot of, at least patients in my area where I practice, are uber rich people who feel, I do not know if it is because of the Modi drive, they feel that they need to be very Indian in their approach. They eat only ragi, millet, stuff like that, and then they do kapalbhati and pranayama and all that. So all that is good. And they also use Vicco Vajradanti toothpaste, Dabur. Yeah, so they feel that Indian, I'm also hardcore Indian. That's the reason why I didn't leave India, even though I had a lot of alliances and propositions to settle abroad. My brother himself is in Australia. I feel very strongly about India, but sometimes no, there's a fine line dividing clarity and stupidity. Yeah, we may be this way, that way all the time also, but that clarity they don't have. Vicco Vajradanti is probably good, it has got excellent ingredients, but we don't have clinical records to say that it's good. Okay? And a lot of so-called indigenous toothpaste, like which comes with a herbal tag, like Colgate Herbal and Patanjali and Dabur, all that has fluoride in it. Okay? So all those toothpaste also have 1000 parts per million fluoride included in it. They are just again selling because they know that that will sell, right? We don't have hardcore evidence to state that this is better than Colgate. Now, I am also involving myself in that form of research. We did a randomized control trial comparing Meswak versus Colgate Total, which is arginine and fluoride, to see if which is better. Both perform the same. In the end of 1 year, it's not like a 1 month study, followed up patients for 6 months and then at the end of 1 year to see if either of them develop more cavities. And we also monitored both reversible lesions and irreversible lesions. We didn't find a difference in both. But both groups developed equal number of cavities at the end of 1 year. Okay? Maybe if it was a placebo, we don't know how much of the new cavities would develop. So that means it's not just the toothpaste, it's about the brushing technique that they are not aware of. Okay? So that's something that we have not measured, but it makes sense to you. So when you have, in abroad you have something called as water fluoridation. We don't do water fluoridation intentionally because we have a lot of fluoride endemic areas, and government as a policy has provided corrected water in all fluoride endemic areas. There is no space in India currently that has, fluorosis as a problem. Dental fluorosis is a very minor problem. Skeletal fluorosis is actually a very, very big problem, which is kind of debilitating. So government has taken corrective measures. We don't use water fluoridations, though I have read reports that the Bisleri can that we get has got 0.6% fluoride in it. 600 parts per million fluoride in it. I'm not sure, but that's what the report says. But when you have fluoride toothpaste, every time the patient brushes, it spikes, the amount of fluoride spikes in his mouth, which goes above the actual threshold to have an antimicrobial effect. Okay? So that is why fluoridated toothpaste are important, and I would always bat for one. How does it important clinically? Is because when you have lesions like this, these are all remineralizable lesions. You will see this typically in patients undergoing fixed orthodontic therapy. Tomorrow if a patient in your clinic comes with this, then this needs attention then and there. Don't prescribe tooth mousse and all. It's very expensive. If they fancy it, they can use it. But the simple thing is to show the patient, even before you remove the plaque, put disclosing agent, show the patient where they have not brushed and tell them that they need to brush that. And if you use a fluoridated toothpaste, inaccessible spaces where biofilm is retained, fluoride will get incorporated into the biofilm and will continue to have an antimicrobial effect even if they have plaque retained. So that's the reason why fluoride toothpaste are imperative. These days Colgate Total comes with a combination of arginine with fluoride. Arginine is also shown to have very good results to lower the pH of the biofilm. The pH of the biofilm is what is causing the disease. So when you are prescribing Colgate, Colgate salt, Colgate strong teeth vida, arginine. Now I think based on the research of how Colgate Total fared, they have incorporated arginine in all their toothpaste forms. They may promote it as salt containing, charcoal containing, herbal containing, but that's only marketing gimmicks. The thing that actually works in Colgate is the arginine and fluoride. Okay? and they are all backed by strong scientific studies which is published in Q1 peer reviewed articles in a sample size of 3,000 children and 2,000 children. So when they promote, they also have science to back, because regulations internationally like FDA mandates that they provide references like that. I was shocked to see that the national IDA is actually endorsing Dabur. I recently raised it with Dr. Maheshwar. I said this is not done. There are just 2 studies clinically which shows plaque control or something. It does not, there is not even a single study on Dabur toothpaste to show that it prevents cavities as compared to fluoride. So I am just preparing a document. I am like this only revolutionary, I'd go do all these nonsense things. That's why people don't like me. But somebody has to do it, right? So we have to be very careful. So you just look up in PubMed if they have evidence, or even easier, ask ChatGPT to provide with references, it will give you answers. Okay? Moving on to this silver diamine fluoride is very important, because this is something that has a very good niche for you in your practice. It has got silver component and fluoride component in that concentration. Now the silver helps in antibacterial activity, it has effects on the dentine mineral as well as collagen, and so does fluoride. We will quickly see this. So you can see the concentration of fluoride in that, right? It's very, very high concentration. It's like what you, it's even higher than what you will find in your varnish. Okay? So this has an instant and an immediate effect, both silver and fluoride. Now silver part of the silver diamine is predominantly antibacterial. We all know that silver has a huge potential for inhibiting bacteria both at the intracellular level and as well as causing cell lysis. It causes disruptions of the cell wall and cause it to rupture, basically bacteria break and rupture. It causes mutation of the DNA, so that even if the bacteria survives and multiplies, it will not have the same virulence or pathogenicity. And then it also causes inactivation of DNA, RNA, and makes the cytoplasm vulnerable to lysis. I will share all these slides with you. Okay? This I am putting science here because I am not sure if all of you know about the scientific part of it or how it functions. Now what it does on the mineral component is silver kind of precipitates with chlorine phosphate and oxygen to form complexes that instantly hardens the dentine. So they say that when you apply silver diamine fluoride, the soft dentine also hardens instantly. It's because of those precipitates on the mineral. And collagen, it inhibits the MMPs and cathepsin, which basically helps in propagating caries in through the dentine. So when you have MMPs and cathepsin, dentine collagen breaks down much easier. So it helps in preventing that. Now we all know what fluoride does. This is cumulative for any form of fluoride, be it in silver diamine fluoride or your mouthwash or your toothpaste. Only the intensity of the action varies based on the concentration. It's antimicrobial predominantly because it inhibits this enzyme, okay, glucosyl transferase. There are 2 forms of fluorides whenever you use, something that's hardly bound or firmly bound, and one which is loosely bound. Now hardly bound is what is helping in forming, reforming or remineralizing the demineralized crystals in the form of fluorapatite. So that is, if there is complete substitution, then it's fluorapatite, or most commonly it forms fluorohydroxyapatite, okay. But there is also loosely bound fluoride in the form of calcium fluoride, which serves as a reservoir in the future if there is both in the dentine as well as biofilm. If wherever there is demineralization, it helps them to form the firmly bound fluoride. Again, this also inhibits the degradation enzymes present in dentine and hence strengthens the dentine and inhibits caries progression instantly. So if you've not invested, so one product that I would recommend that you invest, especially to manage pediatric kids who are not cooperative for treatment or you don't know what to do, so many cavities, ஐயோ இந்த வாயில் எனக்கு என்ன பண்ணுனே தெரியல அப்படின்னு உங்களுக்கு ஒரு moment வந்ததுன்னா, please use silver diamine fluoride. I'm not going to tell you how to do, this is all there in the manual, hundreds of YouTube videos, you can just look up to that. So but you can see that if this active lesion has to be inactivated traditionally we will apply fluoride varnish. We'll ask the patient to brush, 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 which they may do, which they may not do, avoid sugar and all that. So it's a huge cycle and a lot of variables involved. But when you apply silver diamine fluoride, it instantly hardens and converts it into an inactive carious lesion. You can do this until you can plan something in future. If you are planning something for GA or all that, that comes subsequently, you can do this instantly. One disadvantage of silver diamine is it will leave behind that black scar. Okay? But between an active carious lesion like that and a black scar, we should be able to convince the parents to, at least have this until they decide, or they, mainly when you say GA and full mouth rehab for pediatric patients, only two parameters play on their mind. One is GA VAR, yeah. Second is oblocasa. So until they make up their time, or you feel that you need more time to help them understand, நீங்க வீட்ல போய் யோசிச்சிட்டு வாங்கலாம் சொல்லி வரதுக்குள்ள அந்த பல்லு வேற எங்கயோ போய்டும். So to prevent that, you can do silver diamine fluoride. It's they use potassium iodide to reverse the color. So it's not marketed along with the traditional silver diamine fluoride component, but there are indigenous market. Even Ganesh's company has silver diamine fluoride, which is dispensed along with potassium iodide. So after applying, hardening, rinsing off the silver diamine fluoride residues, you apply potassium iodide. The color kind of becomes from dark black to some grayish color. It doesn't become white, but at least it helps to reverse the color a little bit. Okay?
So for the change in the color, does potassium iodide have any other effect?
No, they don't have, it doesn't soften the dentine back, because then it defeats the entire purpose. So it's just change in the color alone. Okay? But again, the color might tend to come back. Okay? It's not like a permanent change in color. Color tends to come back. Okay? But if you see its application in the front teeth region, where that's where your ECC sets in, it has got a very high success rate of arresting caries. No? If you apply it biannually, it helps in progression, preventing the progression of dental caries. Not so much in the posterior teeth, especially upper and lower posteriors, it's about 60 to 55 to 60%. It's purely because there are other factors in it. Inge vandu you can brush and maintain oral hygiene, but posteriorly, if there is biofilm retention, again you will have cavities progressing. So there you need to either plan for a crown or a filling subsequently. There are huge studies again to see whether bonding to SDF treated dentine is feasible or not. It seems to be good, except that the cavo surface margin should have fresh dentine. If you want good bonding, just have good enamel and dentine on your cavo surface margin. Nadula enna irundhalum paravala. Okay? It can be soft caries also, it can be SDF treated dentine also, it doesn't matter. Just cavo surface margins have to be clean. Now when we say application of fluoride, where all do you use fluoride? நீங்க varnish சொல்றீங்க, SDF சொல்றீங்க, toothpaste சொல்றீங்க, but where do you apply fluorides? For that you first understand what is minimally invasive dentistry and what are the components of minimally invasive dentistry, because fluoride is not a one point agenda with your patient, it is a continuum. Okay? அது வந்து ஒரு மியூசிக் கான்சர்ட்ல தம்புரா மாதிரி வாசினே இருக்கணும். Yeah, it's not like கட்டம் வாசிச்சாங்க அவங்க வந்து ஆலாப்பன பாடினாங்க அந்த மாதிரி கிடையாது. It is there throughout. Okay? So for that, what is minimally invasive dentistry? It involves non-invasive treatment. When I say non-invasive, it includes prevention, remineralization and treating cavitated lesions as well. When you are not doing a filling, it is non-invasive. Okay? Next is micro-invasive, which is sealing and infiltration. You all have heard of resin infiltration, right? Adu or tani class. Okay? So micro-invasive concepts are also very interesting, extremely radical from what we learnt in dental school. Nobody is teaching that again here. So there's a huge scope. Invasive is what we currently do. Mixed interventions are both Hall techniques in pediatric practice and Rond restorative caries. Okay. These are the factors that you need to see in your patient's mouth when you are looking at prevention, remineralization and maintenance. Is the caries active? Is the caries cavitated? And is the tooth in a cleansable area? Okay, and then there's this algorithm. Based on the algorithm, you see what you do. If everything is sound, there is no active caries and no cavities at all, you still need to do fluoride varnish to prevent caries from happening. So when we say no intervention, it doesn't mean that you just send the patient. You can do fluoride varnish biannually and prescribe a fluoridated toothpaste. Other things just vary. There is an algorithm for that also. Next is occlusal caries. You won't believe the conferences that I attend, no? They have symposiums on Saturdays. They don't have guest lectures and all. இவர் வந்து பேசினாரு, அவர் வந்து பேசினாரு, இவருக்கு பட்டம் கொடுத்தோம், அவருக்கு பதவி கொடுத்தோம், ஒண்ணுமே கிடையாது. Everybody presents only poster. One person gives guest lecture who receives the lifetime achievement award in cariology for that year. Okay? Rest is they have only symposium. So one symposium during a conference, it happens on Saturday morning till afternoon. One day was biological aspects of occlusal pit and fissure caries. Adoda biological aspects, not clinical aspects or treatment aspect, only the biology. They spoke about that for 5 hours. It is mind-boggling the way they have gone into the depths of what is happening with cariology. Poland is caries free. Poland doesn't have caries. Most of the Nordic countries are facing a different kind of challenge. என்னன்னா அவங்க வந்து they are heavily dependent on AI. So the last year symposium was AI in teaching cariology for dental students. A Nordic experience அப்படின்னு வந்து பேசுனாங்க. என்னடா பேச போறாங்க, இதில் என்ன சொல்லிக் கொடுக்கறது கஷ்டம், எதுக்கு இதுக்கு AI அப்படிலாம் பார்த்தோன்னா அவங்க பேஷண்ட்ஸில் கேவிட்டிஸே இல்லை. So we cannot take photo and show how cavities look. So we are using AI to generate clinical possibilities of cavities to teach our students. Can you believe it? Dentist. So dentist என்ன செல்வாங்க? So this is actually a very good question. அப்போ போலாண்ட்லலாம் dentist என்ன பண்றாங்க? The fact that they are coming and attending ORCA conference itself shows that they are very well off, because the registration fee for the previous ORCA conference was 68,000 rupees. Okay, காசு இல்லைன்னா யாரும் வர மாட்டாங்க. இதில் ஸ்விட்சர்லாண்டில் எப்படி ப்ராக்டிஸ்னா, நீ என்ன வேணால் வந்து பண்ணிக்கோ, லைக் எக்ஸப்ட் implants and ortho, barring that, which is like, or full mouth rehabs, 1 hour you come and do whatever treatment you are doing, you will be charged 350 Swiss francs. நீ வந்து ஒரு மணி நேரம் உட்காந்து சும்மா பேசிட்டு போனாலும் 350 Swiss francs. அந்த 1 hourலேருந்து 1 hour 5 minutes ஆனால் 700 Swiss francs. அதாவது அவர் பேசிஸில். They don't charge for treatment. They charge, this happens in University of Bern. My friend is the CEO of that university. He says that everybody is happy. Patient வந்து பேசினே இருக்கிற patient காசு கொடுத்து தான் போகணும். இங்கெல்லாம் நம்ம அந்த மாதிரி சார்ஜ் பண்ண முடியுமா? 500 ரூபாய்க்கு மேலே போனால் மூக்கால அழுவாங்க. நீங்கள் என்ன பண்ணிட்டீங்க அப்படின்ட்டு நீங்கள் அவ்வளோ வாங்குறீங்க? சும்மா பேசுதானே பேசணும், அதான் சும்மா கேட்டுட்டு போகலாம் தான் வந்தேன். So see, it's about how collectively everybody is changing, right? I feel, with all due respect, in India the problem is not with patients, it's not with problems, it's problem with dentists. We undermine our own profession. அவன் 1000 ரூபாய்க்கு பண்ணுறான்னா நான் 800 ரூபாய்க்கு பண்ணி தரேன், நீ 800 ரூபாய்க்கு பண்ணுறியா நான் 500 ரூபாய்க்கு பண்ணி தரேன். இந்த மாதிரி ப்ராக்டிஸ் பண்ணோன்னா then there is no scope for, we are having 1.5 billion population. ப்ரிவென்ஷன்னு பிரித்து பண்ணோன்னா எல்லாருமே மில்லியனர்ஸ் தான். அது எப்படி பண்ணணும்னு நான் சொல்கிறேன். And then this is again an algorithm for proximal caries. For occlusal caries and proximal caries, please take bite wing radiographs, otherwise you will not be able to strategize effectively. Okay? Now this is what I was saying, an algorithm, you can take a printout of this and stick it in your clinic. What to do when? If there is primary teeth, coronal caries, in these 3 aspects, where you will use fluoride, where you will use APF gel, all of that. நான் வந்து APF ஜெல்ல வந்து நீங்கள் ட்ரேயில் போட்டு இப்படி லோட் பண்ணி 2 நிமிஷம் கிளாக் இதெல்லாம் நான் சொல்லி கொடுக்கல, இதெல்லாம் நமக்கு ஏற்கனவே தெரியும். எது எங்கே பண்ணணும் தான் தெரியாது. Yeah, so this is for primary teeth, and you have a huge scope to use SDF in primary teeth. And when it comes to permanent teeth, there is another huge component we all have been ignored is the root surface problems. Okay, whenever you are having periodontal therapy, immediately think about prevention also. You can do so many things. Okay, the fluoride varnish and high end fluoride, we don't get high concentration fluoride toothpaste in India because of regulations, but there is a lot of scope to prevent cavities. You can use SDF. நம்ம வந்து இந்த ரூட் கேரிஸ் பார்க்குறோன்னா அதை நல்லா ப்ரிப்பேர் பண்ணி அப்படி ப்ராக்சிமலாக ஸ்மால் பர்ல டனல் ப்ரிப்பரேஷன்லாம் பண்ணி அந்த ஜிஐசியை வச்சு செலஃபின் ஸ்ட்ரிப்பை வச்சு பண்ணி எடுக்கிறதுக்குள்ளே இங்கேருந்து பிளட் வரும், வெளியிலேருந்து சலைவா வரும், சக்ஷனை சரியாக பிடிக்க மாட்டாங்க, பேஷண்ட் 1000 தடவை மூவ் அதெல்லாம் பண்ணவே தேவையில்லை. நீங்கள் அதே 1000 ரூபா சார்ஜ் பண்ணிக்கோங்க, எஸ்டிஎஃப் அப்ளை பண்ணிடுங்க. உங்களை யாராவது சார்ஜ் பண்ணக்கூடாது சொன்னாங்களா? பேஷண்ட்ஸுக்கு எப்படி தெரியும்? நாம் சொல்கிறது தானே பேஷண்ட்டுக்கு தெரியும். எஸ்டிஎஃப் இது லேட்டஸ்ட்டு இம்போர்ட்டட் ஃப்ரம் ஜெர்மன் டெக்னாலஜி. இதை போட்டிங்கன்னா உங்களுக்கு அப்படியே இருக்கிறதும் அரெஸ்ட் ஆகிடும், இனிமேல் அது மேலே கேவிட்டியே வராதுன்னு நம்ம எப்படி செல் பண்ணுறோமோ அப்படி தான் அவங்க அதை ரிசீவ் பண்ணுவாங்க. இல்லை, அதுக்கு தான் என்ன பண்ணோம், அடுத்த கிளினிக்கோட நம்ம அதை வந்து ஒரு கம்யூனிட்டி மாதிரி கிரியேட் பண்ணி வச்சுக்கணும். See, only one example I will tell you. இந்த ஆட்டோக்காரங்களை எடுத்துக்கோங்க. அவங்க ஸ்டாண்டில் ஒருத்தன் 100 ரூபான்னு சொன்னான்னா வேற யாராவது 50 ரூபாய்க்கு ஓட்டுவாங்களா? மெய்ட்ஸ், வாட்ச்மேனு. ஸோ அந்த மாதிரி ஒரு கம்யூனிட்டிக்கு நான் இப்போ நீங்கள் யார் உங்கள் கம்யூனிட்டி டென்டிஸ்ட்லாம் இருக்காங்களோ பகையாக வச்சுக்க கூடாது. யூ ஷுட் ஹேவ் சோஷியல்ஸ் வித் தெம். ஒரு பாரில் மீட் பண்ணணும், இல்லை காஃபி ஷாப்பில் மீட் பண்ணணும். யூ ஹாவ் டு ஸ்ட்ராட்டஜைஸ். யூனோ இன்ஹெரண்ட்லி இட் இஸ் அது எவ்வளோதான் பியூட்டிஃபுல்லாக பண்ண ரூட் கெனலாக இருந்தாலும் ஏதோ பண்ணியிருக்காங்க. ஸோ அந்த மென்டாலிட்டி மாற்றணுன்னா நம்மலாம் சேர்ந்து இருந்து பண்ணாதான் வேலைக்கு ஆகும்ட்டு. பட் இஃப் யூ இட்ஸ் ஆல் அபவுட் ப்ரமோட்டிங் மேன். I feel in the end of the day, how you project yourself and promote yourself is what patients will look at. You have credentials and you speak from a point of authority, they will definitely listen to you. Okay? So it's about our mindset. We first have to change. Now coming to the most interesting part. So I charge 2000 rupees to apply fluoride varnish in patient's mouth. Okay? At Alvarpet. 2000 rupees. Ma, உனக்கு காஸ்ட் ப்ரைஸே 350 rupees ma, Boko or GC. Okay, so this is a projection for my practice. Okay, I charge 2000 rupees and I do for one patient. If I do twice in a year, I am getting 4000 rupees in his mouth. But when I say prevention, இது பண்ணிங்கன்னா உங்களுக்கு கேவிட்டி வராது, இது ரொம்ப யூஸ்ஃபுல். வராது, கண்டிப்பாக வராது. once in 6 months உங்ககிட்ட வந்தாங்கன்னா கண்டிப்பாக கேவிட்டி வராது. இது நான் சொல்கிறேன்னு கிடையாது. This is how the US insurance system is being strategized, which mandates them to come once in 6 months, not because the people or the dentists are so bothered about prevention. They don't want money to be spent on treatment. Okay, so by protocol, if you follow once in 6 months, patients will not develop cavities. But knowing our patients, they will not come once in 6 months. Yeah, அப்போ கேவிட்டி வந்துச்சுன்னா அது வேற மாதிரி காசு சம்பாதிக்க போகிறோம். நம்ம கையில் பேஷண்ட்ஸை வச்சுக்கணும். ஓகே, ஸோ சே ஃபார் அ ஃபேமிலி ஆஃப் 4, 2 kids, father, mother, you do fluoride varnish biannually, 16,000 from one family. You have 10 such families in 1 month. You will make 1,60,000 rupees. Yeah, in 1 year. Okay, from 10 families. Imagine how many families you are treating. This is for 1 year, because this rate is for 1 year. 16,000 is for 1 year from one family. 10 such families will give you 1,60,000 in 1 year. Your cost of investment, I use GC fluoride, but you can use any fluoride varnish. Fluoride is fluoride only. எங்க லொக்காலிட்டியில் நிறைய கேள்வி கேட்பாங்க, அதனால I'm forced to use company products. So my cost price is around 28,000. So even if I keep it as 40,000, I still make a profit margin of 1 lakh to 20,000 without me being there to sit and do this work. My assistant is going to do this work. This will not be done just like that. This is always preceded by scaling. So scaling in our clinic, we charge 3,600. Yeah? So populate it according to your clinical practice and your rates. I'm not saying that you have to do only this. I'm just saying that in the scope of everything that you're doing, if you include preventive practice, it is going to, நீ ஒன்றுமே அதாவது நோவாமல் நுங்கெடுக்கிறோம் அப்படிங்கிறோம்ல, நம்ம வேலையே பண்ணாமல் நம்மளுக்கு எவனாச்சும் வருஷம் ஒரு 1.6 lakhs ஒரு 1.2 lakhs கொடுக்குறாங்க 10 ஃபேமிலி பார்த்துக்கிறதுக்கு. Just 10 families. Imagine if you are going to compound it to 100 families. Depends on the scale of your practice. Yeah? The thing is, we are not told about this, or we have not made to think. We didn't learn about this in dental school. Industry is not promoting it, and we don't have adequate programs to talk health economics. But health economics is very, very important. I believe that as dentists, we should be earning lot more than what we are earning. As dentists, we should be paying our assistants much more than what we are currently paying, because that's the only thing that will raise the value of our specialty in common world. Otherwise, we will keep losing dentists to Ola, Uber and stuff like that, which is, and I'm very saddened to see a lot of dentists taking up the skin treatment and not PRP and all that. We should not be doing any of those treatments unless you are an oral and maxillofacial surgeon who is trained and certified to do that. I personally don't like dentists going and doing fillers in somebody's face. We have a lot of, இது வந்து just a preventive practice. இதே மாதிரி periodontal practice is a huge area where you can make money. 20% of Indian population is diabetic. All of them need periodontal attention. How many diabetics are we converting to flaps or curettage? 0. Yeah? It is about how we, sometimes we have to also bend down and scare our patients. Otherwise, they are not going to take up that treatment. So if we begin to do that, take pride in whatever our skills are and our strengths are, and not get just bogged down by industry all the time. Don't go behind products and how to make your clinic more and more fancy. Talk about this kind of prevention and other important science related things in your social media if you are doing stories and reels. Yeah, that will be very, very helpful. And IDA also at some point should engage with the general public. இப்படி சண்டே நம்ம மீட் பண்ணுறது நல்லா இருக்கு, ஊருக்கு போகிறது வெக்கேஷனுக்கு போகிறது நல்லா இருக்கு, பட் ஆனால் எவ்வளோ dentists through IDA have actually gone out and educated the public? Nobody. I have not seen any IDA take that initiative. ஏதோ இப்போ தான் endodontist, we are giving statement on All India Radio, Times of India about importance of root canal treatment. Prosthodontists do that for their specialty. That too, that's happening in the last 5 years. I think it's the duty and responsibility of IDA to connect with the public rather than keep educating dentists over more and more. பேஷண்ட்டே இல்லாத பட்சத்தில் நம்ம இவ்வளோ ஸ்கில்ஸும் நாலேஜும் அக்வயர் பண்ணி யார் மேலே ப்ராக்டிஸ் பண்ண போகிறோம்? கரெக்டா? இப்போ தீருபாய் அம்பானி வந்து சிம் விற்கிறான்னா எப்படி ரோட்டுக்கு ரோடு பந்தல் போட்டு ஃப்ரீயாக கொடுத்துருந்தான்ல ஜியோ சிம், அவனை மார்க்கெட்டிங்கில் பண்ணானா இல்லை டிட் ஹீ ட்ரெயின் ஹிஸ் எம்ப்ளாயீஸ் டு ஸ்பீக் வெல்? நோ. You have to connect with the public in order for them to take up. My question is only one thing. People spend 2,000, 3,000 rupees on getting nail art done. Yeah? People, and the minimum, if you go for skin care thing, which dermatologists are doing these days, you will have to shell out 1,000 rupees. That too, that does not last long. It just lasts for 3 weeks, 4 weeks. When they have, it's not like they don't have the money. they have been enticed to spend. நீங்கெல்லாம் எப்படி you are all enticed to spend on products because industry drives you to that. They are also enticed to spend on beauty because people are being, that's glamorized. So let's glamorize dentistry and put, this is nothing, it costs you nothing to invest in preventive practice, but the returns will be long term and you will gain a reputation of somebody who prevents. Okay, that has got a very sort of the esteemed position in society, that I am a very preventive dentist. I am really concerned that you don't develop problems. People will like you more. Yeah. Next and final thing is about fluoride toxicity. Have you all come across this debate of neurotoxicity with fluorides? Has any of your patients asked you fluoride வந்து childல வந்து neurotoxicity cause பண்ணுது, IQ கம்மி ஆயிடுது? It all started with this controversial paper in Environment Health Prospects, which published a systematic review which showed that avanga state, so that's the problem, no, we don't read papers. Yeah, but companies will take this to their advantage. So what are they saying? Conclusion: support the possibility of an adverse effect of high fluoride exposure on children's neurodevelopment. Nothing is defined. What is high fluoride exposure? 3.6 grams க்கு மேல போச்சுன்னா இந்த அசோசியேஷன் வரும்ட்டு அந்த சிஸ்டமேட்டிக் ரிவ்யூல சொல்லியிருக்காங்க. பட் that high fluoride exposure was not highlighted. உடனே water fluoridation kids fluoride is causing neurotoxicity, we are making our kids dumb அப்படின்ட்டு there were so many reports. Even Harvard published a paper in 2012. After that paper came that impact of fluoride, so we should tread with caution when we are prescribing fluoride, this, that. Such a hue and cry happened. If you go to Bangalore and see, half of the dentists are not prescribing fluoridated toothpaste. They are in fact promoting non-fluoridated toothpaste. There's a company called Perfora. So they are also promoting nanohydroxyapatite with zero research on that. Nanohydroxyapatite வேற எவனோ எங்கேயோ research பண்ணி சொல்லியிருக்கான் it is good. But நீ உன் டூத்பேஸ்ட்டில் டெஸ்ட் பண்ணியா? அதோட bioavailability in Perfora என்ன? There is no report. But they are all citing this paper, both from Harvard and the previous paper, saying that fluoride causes neurotoxicity. It is a huge problem because French government of late recently is planning to ban fluoride. Whole of Europe is looking at banning fluoride. Fortunately, 3 days back, this report came. This is in fact an article in January and Hindu, which shows that there is a link between fluoride levels and IQ loss. இப்படி யாருமே nobody reads the full paper, right? They'll only read the title, oh my god, doctor இவங்க வேற fluorideங்கிறாங்க, ஆல்சைமர்ஸ் வரும்னாங்க, இந்த அம்மா வேற வந்து கேரியாலஜியில் fluoride பண்ணுன்னு patient வந்து, that's why I put this. These are all already there. If this is here, it will be there on Instagram, Facebook and all social media. Fortunately, there are publications that came out which said that this is, we don't have water fluoridation, but in countries which does use water fluoridation says that until clear evidence exists that water fluoridation lacks public health benefit or compelling evidence of harm at the level of fluoride exposure in water fluoridation, it is less than 1000 parts per million. And the level nobody has established harm. Okay, so the US government has come forth to saying that we don't have evidence to show that it is causing IQ loss. Only when the fluoride is ingested or subdermally absorbed. What as dentists we need to understand is there are a lot of dermatological products which also uses fluoride. And when you use fluoride skin care, it gets absorbed into the bloodstream, systemic circulation, and that probably has hormone disruption, IQ effect, Alzheimer's and all that. But nothing has been proved with fluoride in regards to dentistry. Okay, and this is again, this paper came 3 days back. Okay, I'm very happy that this paper came because it was very useful for me to share with you guys that childhood exposure of fluoride actually has a marginal improvement in cognition in them, which means they are intellectually marginally better off. It doesn't cause it doesn't make people dumb, in fact it can make them a bit smarter, is what is come. Again, it is the Science Advances is from Science Journal. It's a very reputed journal. So if somebody says fluoride is toxic, you say that yes, these reports were there, but that was for high level of fluoride intake, mostly from cosmetic. What happens is, the blanket French government wanted to ban fluoride in use in cosmetics. Okay, unfortunately toothpaste comes under cosmetics. Toothpaste per se is categorized as a cosmetic enhancer, and it doesn't come under health. So by default they had to remove fluoride from toothpaste. So they were going to promote non-fluoridated toothpaste, and 2 days back we had our board meeting at Orca, which we wanted to represent to the French government, saying that this is going to be very detrimental, because till date we don't have any other proven method to prevent cavities other than fluoride. CPP, ACP doesn't prevent cavities when used alone. It works only when you use it along with fluoride. So the argument is, when you don't have an equal or a better alternative to fluoride, you cannot withdraw it. And with this current reports which says that fluoride is good in a way, it does not cause harm in the dosage that it is recommended, it is safe to use. Okay. So with this I conclude. I am extremely grateful to the previous institution where I was employed, because that is where I embarked on the journey of cardiology, and of course my alma mater, Savitha Dental College. It has changed its face right now. இந்த மாதிரி நான் போடலைன்னா வந்து அவங்க கோச்சுப்பாங்க. Temple of Dentistry. But I like the previous view. I don't know how many of them endorse, but you know, to each their own. People might feel that this is good, but the science remains the same, whether it's just the facade that is changed. But Savitha is a great institution. At least it's given me a platform to, you know, talk about things that needs to be heard. So that is what has fetched me a role in the along with the Tamil Nadu state government to effect the oral health policy. So without Savitha's platform, I don't think I would have reached there. So thank you all for listening to me patiently. நான் சொன்னதை விட ஜாஸ்தி பேசிட்டேன், சாரி.